Walk me through the equipment used in a major OT. How does it differ from a minor OT?
In a major operating theater, OT, the equipment is designed for high acuity, lengthy, and complex procedures, whereas a minor OT is equipped for brief, less invasive surgeries that typically require only local or regional anesthesia. In a major OT, the infrastructure is built for life support and advanced monitoring. This includes a high-end anesthesia workstation with built-in ventilators and multi-parameter monitors that track ECG, oxygen saturation, end-tidal carbon dioxide, and invasive blood pressure. The lighting consists of ceiling-mounted, shadowless LED lights, and the room utilizes laminar airflow systems to maintain a sterile, positive pressure environment. You will also find specialized surgical tables that can be adjusted for complex positions like prone or lateral, along with advanced imaging tools like the C-arm for real-time X-ray guidance. Conversely, a minor OT is significantly more streamlined. It generally features a basic procedure light, a simplified patient monitor for vital signs, and a straightforward procedure bed or stretcher. The instruments are kept to the minimum required for local procedures, such as suturing, minor biopsies, or foreign body removal. While a major OT requires extensive sterile processing and a large sterile supply area, a minor OT typically focuses on basic surgical site preparation and uses a smaller set of instruments that can be efficiently sterilized. Understanding this distinction is key to ensuring you are prepared for the specific level of care each environment demands.
Tell me the specific equipment used for laparoscopic versus open major surgeries.
Laparoscopic and open major surgeries require fundamentally different equipment sets to achieve the same surgical goals. In laparoscopic surgery, the focus is on minimally invasive access and high-definition visualization. The essential equipment includes a laparoscopic tower, which houses the high-definition video monitor, light source, and insufflator used to inflate the abdomen with carbon dioxide for better working space. Surgeons use specialized trocars to create small ports for entry and then insert long, thin, rigid instruments such as laparoscopic graspers, scissors, needle drivers, and energy devices like hook cautery or harmonic shears. Because the surgeon operates by viewing a 2D or 3D screen rather than looking directly at the site, precision and camera management are vital. In contrast, open major surgery requires traditional instruments designed for direct manual access. This setup includes a wide variety of scalpels, heavy-duty surgical scissors, and diverse metal retractors, such as self-retaining or handheld Deaver or Richardson retractors, which are necessary to hold larger incisions open for deep visualization. Surgeons rely on direct sight and tactile feedback, so the instrument table is packed with various tissue forceps, clamps, and needle holders that allow for manual manipulation, suturing, and tissue repair. While both approaches use advanced technology for cauterization and hemostasis, open surgery relies on larger-scale, robust tools that prioritize direct physical control over the surgical area.
Tell me the specific equipment used for hip replacement surgery.
For a total hip arthroplasty, THA, the surgical team utilizes a combination of specialized orthopedic instruments and standard major operating theater equipment. My role as the nurse is to organize this setup for maximum efficiency and patient safety. The essential equipment includes a comprehensive orthopedic tray containing specialized reamers for both the acetabulum and the femoral canal, which ensure the bone is precisely shaped for the implant. I prepare various impactors to securely seat the components and a series of trial implants used by the surgeon to verify the correct size, fit, and range of motion before finalizing the placement. Power tools, such as drills and surgical saws, are calibrated and tested before the procedure to allow for the clean removal of the damaged bone. During the surgery, I manage the pulse lavage system to thoroughly clean the bone surfaces, which is critical for successful cement bonding or press-fit fixation. I also facilitate the use of a C-arm for intraoperative imaging to confirm the accurate positioning of the components, ensuring that all team members strictly adhere to radiation safety protocols. Throughout the procedure, I maintain a formal, continuous count of all sponges, sharps, and the small orthopedic components typical of this replacement system to ensure none are left behind.
Describe the specialized equipment and instrument sets required for a craniotomy.
A craniotomy requires a highly specialized set of instruments designed for precision, bone work, and delicate handling of brain tissue. As a nurse, my role is to ensure these high-value instruments are prepared, accounted for, and handled with extreme care to maintain sterility and function. The core equipment begins with a high-speed pneumatic or electric craniotome, which is a specialized drill used to create burr holes and cut the skull bone safely. Along with the drill, we use specialized bone-cutting forceps, rongeurs, like Carrison punches to enlarge the opening. To expose the brain, we use a specialized head fixation system, such as a Mayfield clamp, which keeps the patient's head completely immobile during the procedure. For the soft tissue and brain work, we use an array of microinstruments, including fine bayonet forceps, microscissors, and specialized microdissectors. Because visibility is limited in deep, narrow cavities, a surgical microscope is essential for magnification, often accompanied by microsuction tips to gently clear blood and fluid without damaging delicate structures. Hemostasis is critical during this procedure, therefore, we use bipolar cautery specifically calibrated for neural tissue and bone wax to stop bleeding from the skull edges. I also ensure the presence of neuropatties, cottonoids, which are used for gentle retraction and protecting the brain. Finally, a specialized closure set is prepared, including microplating kits to secure the bone flap back into place once the surgery is complete. I pay close attention to the count of these tiny, specialized items to ensure total patient safety throughout the operation.
What are the essential components of a laparoscopic cholecystectomy set, and how is the trocar placement managed?
A laparoscopic cholecystectomy set is designed for minimally invasive access to the gallbladder and requires a specific array of specialized instrumentation. The essential components of the set include a Veress needle or a Hasson trocar system for safe initial abdominal entry, followed by a series of trocars that serve as ports for instrument access. The surgical tray contains long, slender instruments such as Maryland dissectors for tissue separation, laparoscopic scissors for cutting, and traumatic or atraumatic graspers to manipulate the gallbladder. A critical addition is the clip applier, which is used to secure the cystic duct and cystic artery, alongside a cautery hook or harmonic shears for dissection and hemostasis. Trocar placement is a highly controlled process managed by the surgeon, typically starting with an umbilical incision. The primary, or camera, port is placed first to allow for visual confirmation of the abdominal cavity. Once pneumoperitoneum is established through carbon dioxide insufflation, the surgeon inserts 3 additional working ports under direct visualization to prevent injury to underlying viscera. The placement pattern, often referred to as the subcostal approach, ensures optimal triangulation, allowing the instruments to converge on the gallbladder without crowding. As the nurse, my responsibility is to prepare these ports in order of size and function, ensuring the trocars are locked securely and that all cables and camera heads are connected and white balanced before the procedure begins. Maintaining the integrity of these ports is vital throughout the surgery to ensure that instruments can be exchanged smoothly while maintaining a constant pneumoperitoneum pressure.
Explain the role of the scrub nurse during a cardiac bypass, CAB, procedure specifically regarding the sternal saw and heparinization.
During a coronary artery bypass graft, CAB, the scrub nurse's role is defined by extreme precision, rapid instrument turnover, and strict adherence to safety protocols. When it comes to the sternal saw, my responsibility begins with testing the equipment, whether pneumatic or electric, before the patient is draped. I ensure the saw is fully functional, the blades are correctly seated, and the battery or air supply is secured. During the sternotomy, I stand ready to receive the saw immediately after the surgeon completes the bone cut, replacing it instantly with sterile bone wax and sponges to achieve quick hemostasis. I must be vigilant to keep the cord or hose away from the sterile field to prevent contamination, and I maintain a strict count of any bone fragments or debris generated during the process. Regarding heparinization, This is a critical pharmacological milestone in a CAB. Before the surgeon cannulates the aorta for cardiopulmonary bypass, I must ensure the systemic heparin has been administered and the activated clotting time, ACT, has reached the required therapeutic range. My role is to verify the dosage with the anesthesiologist and the surgeon, ensuring that the necessary amounts of heparinized saline are prepared for use in the arterial and venous lines. Once the bypass is complete and the heart is ready to be restarted, I am responsible for preparing the protamine sulfate, which is used to reverse the effects of heparin. I ensure the timing of this reversal is synchronized with the surgical team's transition off the bypass machine, constantly verifying that all surgical counts are completed and the chest is ready for closure. Throughout this process, I maintain a clear, continuous dialogue with the perfusionist and the surgeon to ensure that the transition to and from bypass is seamless.
What specialized retractors and equipment are commonly used in an open abdominal hysterectomy?
In an open abdominal hysterectomy, the surgeon requires robust exposure to work safely within the pelvic cavity, necessitating specialized self-retaining retractors and a variety of supportive instruments. The most common tool for this procedure is the Balfour retractor, which uses a central bar and two side blades to expand the abdominal incision horizontally, while a third blade, the bladder blade, is attached to provide downward pressure on the bladder, keeping it safely out of the surgical field. Alternatively, surgeons may use a Buckwalter retractor system, which is a versatile, ring-mounted setup that allows for multidirectional retraction and greater stability during longer procedures. Alongside these retractors, the instrument tray must contain long, curved tissue forceps such as Heaney or Ballantine clamps. These are specifically designed for clamping the heavy ligaments and pedicles associated with the uterus, providing a secure grip that prevents slippage during ligation. Because the surgical site is deep, surgeons also require long-handled needle drivers and Metzenbaum scissors, which allow for precision cutting and suturing in narrow spaces. Additionally, I prepare suction irrigation devices to clear the field of blood or fluid, ensuring clear visibility. My role is to monitor the placement of these retractors to ensure they are not applying excessive pressure, which could cause tissue ischemia, and to manage the exchange of clamps efficiently to facilitate a smooth, systematic dissection of the uterine attachments.
Walk me through the equipment needed for a spinal fusion.
A spinal fusion procedure is highly complex, requiring meticulous preparation of both standard orthopedic instruments and specialized neurosurgical hardware. As the nurse, my primary role is to ensure that the instrument sets and implants, which are often case-specific and expensive, are verified against the surgeon's preference card before the procedure begins. The foundational equipment includes a radiolucent operating table that allows for intraoperative imaging, as the procedure relies heavily on a C-arm for real-time guidance. This imaging is crucial for the safe placement of pedicle screws and rods. I prepare the navigation or fluoroscopy-compatible instruments, which are non-magnetic and calibrated for precision. Specialized retractors, such as the Williams or Wiltz retractor systems, are necessary to maintain clear visualization of the deep spinal structures while minimizing muscle trauma. The core of the set includes high-speed power drills for creating pilot holes in the vertebrae, along with taps and probes to prepare the pedicles for screw insertion. I also set up the rod bending equipment and the specialized screwdrivers used to lock the rods into the pedicle screws. Throughout the procedure, I prepare bone graft material, either synthetic or autograft, which is essential for the fusion process. My responsibility is to manage the inventory of implants, ensuring that every screw, rod, and connector is accounted for and that the sterile field is kept perfectly clean to prevent postoperative infection, which is a major concern in spinal surgery.
Describe the setup for a transurethral resection of the prostate, TRP, specifically regarding irrigation fluids and potential risks like TRP syndrome.
A transurethral resection of the prostate, TURP, setup is distinct because it requires a continuous flow of fluid to clear the surgical field and maintain clear visibility through the resectoscope. The essential equipment includes the resectoscope itself, a specialized endoscope with a wire loop for cutting and cauterizing prostatic tissue, and a high-volume irrigation system. The choice of irrigation fluid is critical in a TURP. Unlike many other procedures that use normal saline, a TURP typically requires a non-conducting, isotonic, or near-isotonic solution, such as glycine, sorbitol, or mannitol. This is because standard saline conducts electricity, which would interfere with the electrosurgical loops used to resect the prostate. The primary risk associated with this fluid is TURP syndrome, which occurs when the irrigation fluid is absorbed into the prostatic venous sinuses during the procedure. If a large volume of non-conducting fluid enters the bloodstream, it can lead to hyponatremia, fluid overload, and metabolic disturbances. As a nurse, my role is to monitor the volume and rate of the irrigation fluid used, as well as the balance between the fluid hanging and the fluid returning into the collection system. Signs of TURP syndrome include restlessness, confusion, nausea, or changes in blood pressure, and I must communicate these immediately to the anesthesiologist and surgeon. My responsibility also includes ensuring the irrigation bags are changed promptly to prevent the bladder from collapsing or the field from becoming obscured by blood, all while maintaining the sterile integrity of the entire drainage system.
Describe the setup for a transurethral resection of the prostate, TRP, specifically regarding irrigation fluids and potential risks like TRP syndrome.
The most critical piece of equipment unique to a thyroidectomy for patient safety is the intraoperative nerve monitor, IONM. The primary goal of using this technology is to identify and protect the recurrent laryngeal nerve, which runs in close proximity to the thyroid gland. Damage to this nerve during the procedure can result in vocal cord paralysis and significant voice changes. The IONM system functions by utilizing an endotracheal tube embedded with surface electrodes that are positioned at the level of the vocal cords. As the surgeon dissects near the nerve, they use a specialized stimulating probe, often a fine, insulated instrument, to send a mild electrical signal. If the recurrent laryngeal nerve is intact, the probe triggers the vocal cords, which the endotracheal tube then detects and converts into an audible signal or a visual waveform on a monitor. Beyond the monitor, the surgeon utilizes a variety of fine-tipped instruments, such as non-stick bipolar forceps and microdissectors, to gently separate the delicate nerve fibers from the thyroid tissue. Because the surgical field is small and blood loss can easily obscure visibility, I ensure the suction system is ready with narrow, soft-tipped tips to safely clear the area without applying pressure to the nerve. My role is to calibrate the monitor before the surgery starts, confirm the electrode placement with the anesthesiologist, and remain alert for any changes in the signal intensity during the dissection. This technology provides a constant safety net, allowing the surgical team to map the nerve's course throughout the procedure and confirm its functional integrity before final closure.
Describe the equipment required for a C-section, focusing on the APGAR setup and immediate neonatal care requirements.
For a cesarean section, the equipment setup must support both the surgical delivery and the immediate transition of the newborn. My role is to coordinate these two simultaneous workflows to ensure the best outcome for both mother and baby. For the maternal side, the setup includes a standard major abdominal surgery tray with specialized instruments like C-section retractors, such as the Doyen or O'Sullivan-O'Connor, which provide the wide, stable exposure needed to access the uterus safely. I also prepare a variety of atraumatic clamps and a range of surgical scissors, alongside a well-stocked supply of suction tips, as fluid management is crucial during the delivery. The APGAR setup and neonatal care area must be pre-warmed and prepared before the first incision is made. This area requires a radiant warmer to keep the newborn at a stable temperature. The equipment includes a neonatal suction device, using soft-tip catheters or bulb syringes, to clear the airway, a bag mask ventilation system sized appropriately for a newborn, and a pulse oximeter for monitoring oxygen saturation. I also ensure a sterile supply of blankets, a temperature probe, and identification bands are ready. If the delivery is high risk, additional items like an intubation kit, neonatal stethoscope, and resuscitation medications are kept on standby. My responsibility is to monitor the timing of the delivery, facilitate the handoff to the neonatal team, and document the APGAR scores, at 1 and 5 minutes, which assess the baby's appearance, pulse, grimace, activity, and respiration. Coordinating this seamless handoff between the sterile field and the neonatal station is the most critical part of my role during a C-section.
Explain the purpose of a C-arm in orthopedic trauma surgery and the radiation safety precautions you must implement for the team.
In orthopedic trauma surgery, a C-arm is a mobile fluoroscopic imaging system that provides real-time, high-resolution X-ray images during a procedure. Its primary purpose is to allow surgeons to visualize internal bone structures, verify the alignment of fractured bones, and guide the precise placement of hardware, such as intramedullary nails, screws, or plates, without the need for large, open incisions. By providing a live view, the C-arm significantly improves the accuracy of implant positioning and reduces the time required for complex trauma repairs. Because the C-arm emits ionizing radiation, implementing rigorous safety precautions is a mandatory part of my nursing responsibilities. The ALERA principle, as low as reasonably achievable, must be strictly followed to protect the surgical team and the patient. Every staff member present in the room must wear personal protective equipment, specifically lead-lined aprons, thyroid shields, and leaded eyewear. These must be inspected periodically for cracks or damage that could compromise their shielding capability. I am also responsible for ensuring that radiation dosimeter badges are worn by staff to monitor cumulative exposure. During the procedure, I facilitate the placement of lead-lined mobile screens between the imaging source and the non-essential staff, and I ensure that any personnel not required near the table remain at an adequate distance, as radiation intensity decreases significantly with distance. When the surgeon or radiographer prepares to take an image, I clearly announce X-ray on, to alert the team to step back or adjust their position. By strictly controlling the duration, distance, and shielding, I ensure that the diagnostic benefits of the C-arm are achieved while minimizing the risks of radiation exposure for the entire theater team.
What are the clinical signs of malignant hyperthermia, and what equipment/medications must be in the MH cart?
Malignant hyperthermia is a life-threatening, inherited reaction to certain anesthetic gases and the muscle relaxant succinylcholine. The clinical signs are a result of a hypermetabolic state in the skeletal muscles. Early indicators typically include unexplained tachycardia, often the first sign, followed rapidly by tachypnea, rising end-tidal carbon dioxide levels, and muscle rigidity, particularly in the jaw, known as trismus. As the reaction progresses, patients experience profound hyperthermia, though this is often a late sign, alongside arrhythmias, unstable blood pressure, and dark-colored urine due to rhabdomyolysis. The emergency management of this condition requires immediate access to the malignant hyperthermia, MH, cart. The most essential medication is dantrolene sodium, which is the specific antidote that halts the hypermetabolic process by stabilizing the sarcoplasmic reticulum. The cart must contain at least 36 vials of dantrolene, along with sterile water for reconstitution, as the drug must be mixed rapidly. Beyond the medication, the cart must be equipped for cooling the patient, including cooling blankets, refrigerated intravenous saline, and ice packs. It should also house advanced monitoring equipment to continuously track core temperature, arterial blood gases, and electrolytes to manage metabolic acidosis. Because rapid resuscitation may be needed, the cart also contains emergency medications like sodium bicarbonate for pH correction, calcium chloride for hyperkalemia management, and antiarrhythmic drugs like lidocaine or amiodarone. Having this cart easily accessible and ensuring that the entire OT team is familiar with the location and preparation of these items is vital for patient survival.
Walk me through the steps of a surgical timeout WHO checklist. What happens if there's a discrepancy?
The surgical timeout is a critical safety pause mandated by the World Health Organization, WHO, surgical safety checklist. It must occur immediately before the first incision is made, and every member of the surgical team, the surgeon, the anesthesiologist, and the nursing team, must stop their tasks, turn their attention to the patient, and actively participate. The process begins with a formal introduction where every person in the room states their name and role. Once verified, the team confirms the identity of the patient, the specific surgical site, and the procedure being performed. The surgeon and anesthesiologist then discuss the critical steps, expected duration, and anticipated blood loss. The nursing team verifies that all essential equipment, implants, and sterile supplies are ready, while the anesthesiologist confirms that all necessary safety checks for anesthesia, including medication allergies and airway risks, are complete. If a discrepancy is identified during the timeout, the surgery must not proceed. It is the responsibility of any team member to call the timeout to a halt if there is any uncertainty regarding the patient's identity, the site of the surgery, or if an essential piece of equipment is missing or unsterile. If there is a disagreement or confusion, the team leader must facilitate a resolution before moving forward. This might involve rechecking the patient's wristband, reviewing the medical records, or contacting the nursing supervisor or the surgeon's office. The safety of the patient always takes precedence over the schedule. The delay is not viewed as an error but as a successful, near-miss, catch that has protected the patient from a potentially catastrophic surgical mistake.
Describe the setup and safety checks required for a pneumatic tourniquet before a limb surgery.
The use of a pneumatic tourniquet is critical for creating a bloodless field during extremity surgery, but it requires strict adherence to safety protocols to prevent nerve damage and tissue ischemia. The setup begins with selecting the correct cuff size, which is based on the limb circumference. The cuff must be wide enough to overlap properly, typically covering about 50% to 70% of the limb circumference. Before application, I place a layer of stockinette on the skin to provide padding and protect against friction burns, ensuring the skin is clean and dry. Once the cuff is applied, it is secured firmly but not excessively tight. Safety checks are non-negotiable and start with the pneumatic machine itself. I perform a self-test of the device to ensure the tubing is free of kinks or leaks and that the alarm system functions correctly. I calibrate the pressure settings based on the surgeon's preference and the patient's systolic blood pressure, as the tourniquet must be inflated to a pressure sufficient to stop arterial flow but not so high that it causes mechanical damage. During the surgery, I document the exact time of inflation and continuously monitor the duration. To minimize the risk of ischemia, I track the tourniquet time and alert the surgeon every 30 to 60 minutes. If the surgery exceeds the recommended time, I may facilitate a brief period of reperfusion by deflating the cuff, while keeping the sterile field and patient status fully managed. Upon deflation, I prepare for potential reactive hyperemia and closely monitor the patient's hemodynamic stability as the blood flow returns to the limb.
Explain the difference between monopolar and bipolar cautery and the safety checks for the ESU.
The primary difference between monopolar and bipolar cautery lies in how the electrical circuit is completed. In monopolar electrosurgery, the electrical current flows from the active electrode at the surgical site through the patient's body to a dispersive electrode, commonly called a grounding pad, which is placed on a large, well-vascularized muscle mass. Because the current must travel through the patient's body to reach the grounding pad, this method carries a higher risk of accidental burns if the pad is poorly positioned or if the current finds an alternative path to the ground. Bipolar electrosurgery is fundamentally different because the current flows only between the two tips of the bipolar forceps. The current enters through one tip, passes through the targeted tissue held between the tips, and returns immediately through the second tip. This localized circuit means the current does not pass through the patient's body, which significantly reduces the risk of unintended burns and makes bipolar cautery safer for use near delicate structures like nerves or in patients with cardiac pacemakers. Safety checks for the electrosurgical unit, ESU, are essential to prevent fire and electrical injury. Before the procedure, I ensure the ESU generator is positioned safely and that the power settings are verified against the surgeon's preference. For monopolar use, the most critical check is the application of the grounding pad, I ensure the skin is clean, dry, and free of hair, and that the pad is placed over a large, fleshy area with full skin contact. I also perform an impedance check, which is usually integrated into modern ESU generators, to confirm the pad is securely attached. Throughout the surgery, I maintain the ESU pencil in a holster when not in use to prevent accidental activation and monitor the surgical field for any evidence of pooling of flammable prep solutions or oxygen buildup. Regularly verifying the integrity of all cables and ensuring that the patient is not in contact with any conductive metal surfaces, like the operating table frames, remains my top priority for electrical safety.
Explain the different surgical positions and the padding equipment used for each.
Patient positioning in the operating theater is a critical nursing responsibility that directly impacts surgical success and patient safety. For supine position, where the patient lies flat on their back, we use gel pads under the heels to protect them from pressure sores and arm boards with padding to keep the arms safely abducted. We also place a soft gel ring under the head to prevent occipital pressure. For a prone position, where the patient lies face down, we use chest rolls or bolsters running from shoulder to hip to allow the diaphragm to move freely for breathing. A specialized foam headrest with a mirror is essential to protect the face and eyes while allowing the anesthetist to see the patient. We also place padding under the knees and ankles to prevent nerve compression. For lithotomy position, used in gynecological surgeries, we use well-padded stirrups to support the calves and prevent peroneal nerve injury. Both legs are lifted and placed simultaneously to avoid hip strain. For lateral position, used for kidney surgeries, we place an axillary roll just below the down arm to protect the brachial plexus from compression. We put a pillow between the legs to keep the knees and ankles from pressing together. For the Trendelenburg position, where the head is lowered, we use padded shoulder braces to prevent the patient from sliding up on the table. For reverse Trendelenburg, we use a footboard to maintain position. In beach chair position for shoulder surgery, we use a specialized headrest to support the head safely. Throughout any position change, we work as a team to ensure all tubes and lines are secure and all bony prominences are padded. The goal is always to provide excellent surgical access while protecting the patient from any positioning injury.
Describe the count protocol for sponges and instruments. What is the procedure if a count is incorrect?
The surgical count protocol is the most fundamental safety measure in the operating room. It is designed to ensure that no foreign objects are left inside a patient. This process is a collaborative, dual verification effort between the scrub nurse and the circulating nurse. The counts are performed at specific intervals. The initial count occurs before the incision while all items are in their original state. Intraoperative counts happen whenever additional items are added to the field. The first closing count takes place as the surgeon begins to close the cavity, and the final closing count occurs during skin closure to ensure the field is completely clear. The scrub nurse and circulating nurse perform this out loud, counting every single item together, and each item is recorded by the circulator on a count board. If at any stage the counts do not match, the situation is handled as a surgical emergency. The circulating nurse must notify the surgeon immediately so that the procedure can stop. The entire team conducts a systematic search of the sterile field, the floor, the trash, the linen hampers, and all equipment around the table. The surgeon performs a thorough visual and manual sweep of the surgical site while the nurse and anesthesiologist monitor the patient for stability. If the item cannot be located, a portable X-ray is brought into the room to scan the patient for the missing object. Finally, the discrepancy must be thoroughly documented in the patient's operative report, including the steps taken and the final outcome, as this ensures complete transparency and patient safety.
What are your responsibilities during a rapid sequence induction, RSI, of anesthesia?
My primary responsibility during a rapid sequence induction, RSI, is to ensure patient safety through meticulous preparation and seamless, proactive assistance. Before the induction begins, I conduct a thorough equipment check to ensure all airway devices, including the suction apparatus, laryngoscope, and varied endotracheal tube sizes, are fully functional. I also confirm the proximity of the difficult airway trolley and prepare all induction and emergency medications in clearly labeled syringes, ensuring they are ready for immediate administration. During the induction phase, I provide precise support by applying cricoid pressure, effectively occluding the esophagus to minimize the risk of aspiration. I maintain this firm, consistent pressure until the anesthesiologist confirms correct tube placement and cuff inflation. Throughout this critical window, I anticipate the provider's needs by efficiently handing over necessary equipment, such as the stylet or inflation syringe, without requiring verbal prompting. Once the airway is secured, I facilitate the connection to the ventilator and immediately attach the end-tidal CO2 monitor to verify tube placement. I maintain a calm, focused demeanor throughout the procedure, ensuring that I am fully responsive to the team's instructions. I understand that during an RSI, every second is vital, and my goal is to sue.
Describe the classification of surgical wounds and how this impacts postoperative care.
Surgical wounds are classified into 4 classes based on the level of contamination present during surgery. These are Class 1 clean wounds, Class 2 clean contaminated wounds, Class 3 contaminated wounds, and Class 4 dirty or infected wounds. This classification helps the healthcare team decide the appropriate postoperative care and infection prevention measures. Class 1 clean wounds are uninfected surgical wounds where there is no inflammation and the respiratory, gastrointestinal, urinary, or genital tract is not entered during surgery. Examples include hernia repair and breast surgery. The risk of infection is very low. Postoperative care includes routine wound assessment, keeping the dressing clean and dry, and monitoring for early signs of infection. Class 2 clean contaminated wounds occur when the surgeon enters the respiratory, gastrointestinal, genital, or urinary tract in a controlled and sterile manner without unusual contamination. Examples include gallbladder surgery and uncomplicated appendectomy. These wounds have a moderate risk of infection, so nurses administer prophylactic antibiotics and closely monitor the wound. Class 3 contaminated wounds include open traumatic wounds, major breaks in sterile technique, or spillage from the gastrointestinal tract during surgery. These wounds have a higher infection risk. Postoperative care includes strict aseptic dressing changes, frequent wound observation, and antibiotic therapy. Class 4 dirty or infected wounds are wounds where infection is already present, such as abscess drainage or perforated appendix surgery. These wounds require aggressive antibiotic treatment, wound cleaning, drainage, and close monitoring to promote healing.